Good morning. Welcome to the session on applications of multi-energy CT in cardiothoracic imaging. I am Prabhakar Rajiah. I'm from Mayo Clinic, Rochester. And with me it's Dr. Fernando K. from UT Southwestern. So in this workshop, we will try to broadly give the current applications of multi-energy CT in cardiothoracic imaging. So multi-energy CT means that we acquire multiple spectrally distinct attenuation data sets from different energies. So we know that the tissues and materials show different properties at different energy levels. Usually at low energy levels, there is a photoelectric predominance, and at a high level, there is a Compton predominance. So by using a process of 2 or 3 material decomposition, we can distinguish tissues more than what is possible with a conventional CT. That is the basic principle of multi-energy CT. So there are different ways of acquiring this data. So there are a lot of technologies which are based on the X-ray source, like a dual source which has 2 different X-ray tubes operated at different energies, or a rapid KVP switching in which there is one X-ray source, but the energy of that source is alternates between high and low energies at each projection. And then we have a dual spin, which is not commonly used. Then we have some detector-based technologies, like a recently introduced dual layer technology. And then there is also photon counting, which has the capabilities to provide more than 2 energy levels. So if you can see this, most of the currently available technologies are able to provide 2 energy information for 2 energy levels. So the correct term is dual energy. We also use the term spectral CT because it is providing multiple spectral data. So they're all the same. So the images that we get from this multi-energy technology, we get different types of images. So of course we get a set of conventional images which is similar to what we get in a routine CT. Now different vendors generate these conventional CTs by different processes. For example, the dual source, they use a blending of high and low energies at different levels, and they can generate a conventional image which looks exactly like your routine image. Whereas in a dual layer CT, because there is only 2 layers of detectors, so the X-rays for generating these images, those 2 layers are treated as essentially 1 layer, and that gives you a conventional image. But the image quality is going to be almost the same as your routine CT. But what we are going to focus more on this talk is the additional images that we can get from these technologies. So some of the examples are shown. These examples are what we commonly use in cardiothoracic imaging. One of the most commonly used is an iodine map, in which the tissues are highlighted based on the amount of iodine they contain, and they are color-coded based on the iodine content. And conversely, the iodine can be removed from the pixels, and what we get is a virtual non-contrast image, which looks essentially the same as a true non-contrast image that you acquire. And then by a process of linear combination, these technologies can also generate virtual monoenergetic images, which means that they mimic images that are acquired using a pure single energy beam compared to the typical polyenergetic beam that we use in our routine practice. And some technologies also give things like effective atomic number, which perform the same function as an iodine map or electron density based images. So in terms of virtual monoenergetic images, most of the technologies can generate from 40 keV to 200 keVs, and sometimes till 190 keVs. So what we do with these images will be discussed in more detail by Dr. K. So basically, as you go lower in energy from 70 keV, which is considered to be the equivalent of 120 kVp, the attenuation of contrast in the image goes high. That's because the energy is going to approximate the K edge of iodine. So we'll have more photoelectric effect, so the contrast looks much brighter, which can be used for improving the signal of abnormalities as well as normal tissues. And as you go toward the other side, above 70 keV, progressively the attenuation decreases, but also the artifacts also decrease. So just a brief about other types of images that we can use in cardiothoracic imaging. So I already told about iodine map. So some of the vendors go one step further and then limit the evaluation of the perfusion only to the areas of interest. For example, in this case, they limit it only to lung tissue. So it will show perfusion only in tissues between a certain number, attenuation numbers. So this is called as a perfusion blood volume or a PBV maps. We can see that it is showing color coding only the lungs. So we can see that there is contrast in the vessels, but it is not color coded. The bones are also visible. So it color codes only the lungs based on the particular attenuation. So broadly, if you want to discuss the utility in terms of the image types, so we can use the iodine maps mainly for looking at perfusion. We can also use the effective atomic number as a substitute. This is used for evaluating perfusion in the lungs, mostly for pulmonary embolism or pulmonary hypertension. We can do the same for myocardial perfusion. We can do delayed enhancement. We can also do some lesion characterization both in lungs and the heart, particularly if you want to distinguish a thrombus from a slow flow or a real mass, or if you want to detect an incidental mass. The virtual monoenergetic images, as I mentioned before, at low energies, we use it mainly for enhancing the vascular signal and boosting the contrast, and at high energy levels, we'll be decreasing the artifacts. And then we also get virtual non-contrast, which can be used for lesion characterization. But if you're doing a multiphasic studies, like in vascular studies, like we do a non-contrast arterial and venous phase, so virtual non-contrast can replace the true non-contrast, and that provides radiation dose savings. I'll briefly highlight a survey which we did recently from the members of the Society of Thoracic Radiology to find what is the common use of dual energy in thoracic imaging. So most common indication happen to be acute pulmonary embolism in the current setting. And if we ask the readers what they feel is the most valuable use, they thought it is chronic pulmonary embolism. And this kind of shows the response of readers to different indications like acute pulmonary embolism, chronic pulmonary embolism, and then others like neoplasms and boosting vascular contrast. So most of the users valued this for acute and chronic pulmonary embolism and also for boosting vascular contrast. So with that, I will let Dr. K talk in more details about specific areas of application.
Good morning, and thanks for the invitation. So I'll illustrate some of the applications. We're going to cover technical troubleshooting, perfusion imaging, ventilation imaging, and tissue characterization. The first case is probably the most common scenario encountered out there, where we don't have good opacification of the pulmonary artery. We know that suboptimal quality PE studies may occur in up to 10%, and many of them will occur due to incorrect timing or injection issues, or even the phenomenon of transient contrast interruption. Here, an example, we can use monoenergetic 50 kV images. It's using the same acquisition to boost the contrast medium signal within the pulmonary arterial circulation. And initial studies using dual source, dual energy CT had already shown an increase in up to 12% of the mean vessel attenuation by using 70 kV images, and with an increase of up to 18% of the mean contrast to noise ratio. And a more recent study with the dual layer, dual energy CTs showed actually an increase in the accuracy for PE diagnosis, so two readers reviewing the images, and a statistically significant increase from 91 and 93% accuracy to 99% accuracy. So we can even increase your diagnostic accuracy with reviewing the lower kV images on PE studies. The same rationale can be applied for using a low dose of iodine. So we can reduce, as in this case, the iodine dose was reduced by 50%. We have decreased the attenuation of the pulmonary arterial circulation, but by using monoenergetic images again at lower kVs, we can actually boost the contrast signal and define the presence here of a subsegmental pulmonary embolism in the right lower lobe. There was a prospective randomized study looking at a protocol with 50% iodine reduction and the use of 50 kV reconstructions in comparison with standard iodine dose and standard CTPA acquisition. And the authors found an increased signal intensity at the pulmonary arteries, increased signal-to-noise and contrast-to-noise ratios, and decreased subjective noise in the segmental arteries. And between the two arms, they found a comparable dose profile and also number of non-diagnostic studies. Another study looked at the best energy levels for looking at different vessels in low-dose, low-iodine studies at dual-energy CT. And they found that for aorta, pulmonary arteries, and pulmonary veins, levels between 50 and 60 kV were the best performing ones in terms of quality, whereas if you're looking at the SVC and brachiocephalic veins, you would use a higher kV of 100 to account for being hardening due to the bony structures and more concentrated contrast at the brachiocephalic veins. That leads us to the other application, which is the use of high kV images to eliminate some of the beam hardening and metallic artifacts. In this case, we have standard images of a patient with heart failure and NELVAD presenting with fever, leukocytosis. And here we can, it's difficult to appreciate around the inflow cannula. It looks like there's some soft tissue or some haziness. And using 160 kV images, we can define the presence of a fluid collection surrounding the inflow cannula, which was further confirmed on surgery. Shifting gears to pulmonary perfusion, which is probably another common application. We can use pulmonary perfusion maps as a way of increasing our diagnostic confidence when diagnosing pulmonary embolism. As in this case, we have a small filling defect in a subsegmental level of the right lower lobe. And we can match that with this wedge-shaped segmental perfusion defect, which traces back to that point of where we find the filling defect. So that would increase our diagnostic confidence in calling a PE in this case. And we can also follow backwards this pathway. I mean, if I miss the opportunity to diagnose the PE on these images, by looking at the perfusion, that wedge-shaped perfusion defect would make me go back and review that images more carefully. So it goes both ways. Again, the nomenclature for these perfusion maps depends on vendors and some minimal differences in terms of methodology. You would find them called as perfused blood volume, iodine no water maps, or iodine density maps. Initial studies with perfusion blood volume in comparison with lung scintigraphy showed the sensitivity of 82% and specificity of 99% to diagnose segmental perfusion defects in patients with pulmonary embolism. And those values were of sensitivity of 77% and specificity of 98% when compared with SPECT-CT perfusion. We can definitely apply that in the assessment of patients with pulmonary hypertension. As we know, VQ scans, they play a significant role in the diagnosis of pulmonary hypertension patients by detecting the ones who have chronic thromboembolic pulmonary hypertension as a cause, which would be potentially treatable with surgery or balloon angioplasty. Here is an example of a patient showing the typical findings with a relatively homogeneous ventilation on the top row and significantly heterogeneous perfusion on the VQ scan, showing multiple segmental perfusion defects which are mismatched with the ventilation images. So here, the multi-energy CT would play a significant role, but not only providing, so this is the same patient, CT would provide the anatomic substrate for those filling defects, so we can see eccentric thrombus here involving the right pulmonary artery and the interlobar artery with all of the features of a chronic pulmonary embolism. And we can not only assess which arteries are involved or the anatomic substrate, but at the same time, with the perfusion maps, we can also appreciate all of those perfusion defects on both right and left lungs. Another case here, we have a ventilation scan on the left side and a perfusion scan showing a mismatched perfusion defect involving the apical and anterior segments of the right upper lobe. And the same patient, again, one could have difficulty figuring out that this patient actually had a PE on this maximum intensity projection. So very subtle findings of decreased caliber of the vessels and paucity of vessels in the right upper lobe in comparison with the left upper lobe. But that becomes more there's more conspicuity on the perfusion blood volume images where we have deficits in perfusion in those corresponding segments, which is also nicely shown on the 3D images. In comparison with scintigraphy, multi-energy CTA perfusion has a sensitivity of 100% and specificity of 92% for detecting CTAF. And in comparison with pulmonary angiography, also a sensitivity of 92% and specificity of 99%. We can also use quantitative parameters from the perfusion maps obtained on multi-energy CT, and those were inversely correlated with mean pulmonary arterial pressure and pulmonary vascular resistance. And we can also use the quantitative parameters to monitor therapy. So differences, this study looked at differences in the quantitative analysis using multi-energy CT before and after balloon angioplasty in CTAF patients. And they found that improvements in the perfusion were correlated with improvements or decrease in pulmonary arterial pressure, in pulmonary resistance, and also increase in the 6-minute walking distance. The quantification of pulmonary perfusion using multi-energy CT relies on the segmentation of the lungs and the use of standardization in terms of how you're going to normalize your lung perfusion. So this is the technique used by single via, which is based on normalization to pulmonary arterial attenuation, actually to 15% of that, which is considered normal pulmonary perfusion. So here we have an extensive pulmonary embolism involving lobar and segmental levels bilaterally. And by applying this quantification method, the left lung had a perfusion of 86% in comparison with 15% of the pulmonary artery. And the mean perfusion in the right lung was 97%, so that those numbers can be used as a quantitative parameter of perfusion. And these parameters in patients with acute PE, they were inversely correlated with the thrombus load, clinical parameters of severity and necessity for ICU admission. Actually, if you average the value in both lungs, and when that value was less than 60%, there's data supporting that there's an increased risk of ICU admission, and those patients could be considered as having significant or massive PEs. And you can also use those tools to monitor treatment. This is the same patient, 1 month follow-up after anticoagulation. You can see on the 3D images a significant improvement in those areas of hyperperfusion. And quantitative analysis, again, now showing normalized values for both right and left lungs with clear, as we can see here, clear left lower lobe pulmonary artery. Shifting to ventilation, this is more of an investigative tool at this point. One can use xenon to assess as an inhaled contrast medium to assess lung ventilation. And this paper here looked at the combination of both ventilation and perfusion scans on dual energy CT in patients undergoing emphysema reduction surgery. Their protocol had 3 acquisitions, one during washing of xenon, second acquisition with washout, and a 10-minute second acquisition with injection of iodinated IV contrast to assess for perfusion. And you can see in those 2 examples before and after the therapy, the improvements in the ventilation, and therefore a better ventilation perfusion match in these patients. We can, xenon, it might be cumbersome to use xenon as a contrast median. So one of the things we can do is use the air as as a natural contrast median. In this case, we have a patient with a post-unilateral lung transplant on the left side with declining lung function, where we see here significant deficit in perfusion, especially in the basilar segments of the left lower lobe. This patient is confirmed to have a large area of air trapping in the left lower lobe, which is consistent with the bronchiolitis obliterans as a complication of his lung transplantation. And by using triple material decomposition, we can actually see that on this coronal reformation of the same case, deficits in perfusion in the left lower lobe basilar segments, which matches with an increased amount of air, showing a dead space related to air trapping in the left lower lobe. So this is a potential application that could be further investigated. Same case, just to prove what we were seeing on the CT. Perfusion scan on that case, deficit in perfusion, which is more evident on the basal segments of the left lower lobe. A ventilation scan with the deficit in ventilation, especially in the basilar left lower lobe, and delayed trapping of xenon on the washout images. Now shifting to tissue characterization, this is also a common use of virtual non-contrast images. Common case, hyperdense material near the right ventricle. Is this pseudoaneurysm, or is this something else? By using virtual non-contrast, we can prove that there was a dropped plagiate in a patient with post-surgery, post-cardiac surgery. So this is an easy application. We can define if something is enhancing or not simply by reviewing the virtual non-contrast images. The CT numbers derived from virtual non-contrast to true non-contrast images, there are several papers showing that the differences are small. This paper here looked at different tissues, and more than 92% of the measurements between virtual non-contrast and true non-contrast were less than 15 Hounsfield units. Another case here, a patient with dyspnea, chest pain, mass a mass in the right suprahilar region with areas of high attenuation. We see another nodule with high attenuation in the left perihilar region. One may question, is this enhancing or is this simply a hyperdense material? By using virtual non-contrast, we can see that that's actually hyperdense material, not enhancing tumor. And in this case, this shape resembles the fingering glove, and actually this was confirmed to be allergic bronchopulmonary aspergillosis in an asthmatic patient. In solitary pulmonary nodules, we can definitely use virtual non-contrast to assess for the presence of calcifications. Sensitivity on VNC images is estimated in about 85%. And in this case, we can tell the presence of popcorn calcifications, which is a benign type, in this patient with a hamartoma. We can also assess in a single acquisition. We don't need to do a Swenson protocol with several pre- and post-contrast acquisitions. If the nodule is enhancing or not, we can do that in a single one. So this study here looked at the 3-minute delay protocol, single acquisition, and enhancement component greater than 20 Hounsfield units was associated with risk for malignancy. This is a negative case, patient with an elongated soft tissue density nodule in left lower lobe with net 0 enhancement on the iodine no water images. So this was a mucocele. It was stable for a long time. Another case here with surgical confirmation, a difference between virtual non-contrast and contrast-enhanced images of about 2 Hounsfield units. This was a surgically proven schwannoma. And this case here was a patient with a new pleural effusion and a new nodule in the left lower lobe. Here we can see a difference of about 40 Hounsfield units between virtual non-contrast and standard contrast enhanced images, and that was a lung adenocarcinoma. So sensitivity for using this approach is estimated in 92% with specificity of 70%. And this is all still based on studies done in the end of the 2010 decade. So there's no new data on that. But that confirms previous data on standard CT with pre and post contrast imaging. In oncology, there are several promising roles for dual energy CT. Yesterday, we had a lecture on quantitative biomarkers, which commented on the therapy response. So I'm going to present a different application I selected in the assessment of malignant nodal metastasis, which is a common issue for standard CT. We rely on size, which is not very sensitive, as you may know. By using iodine density, we can increase the sensitivity. Like in this case, we have a borderline lymph node in the patient with a right-sided lung cancer. Measuring the density of iodine in that lymph node, we have 3.1 milligrams per ml. That lymph node was avid on FDG PET and was proven to be metastatic on transbronchial biopsy. So one of the studies that was done in this assessment of nodal metastasis revealed that iodine densities measured at the lymph node greater than 2.9. They had a sensitivity of 80% and specificity of 65% to detect nodal metastasis, which is probably higher. This did not compare with directly with size, but we know that size criteria will have a sensitivity of about 60% for detecting nodal metastasis. There are other papers on also looking at mediastinal tumors, and iodine concentrations greater than 1.4 milligrams per ml are also predictive of other mediastinal malignancies. And I'm not going to comment on myocardial perfusion. We had two great lectures this morning about the use of dual energy CT for assessing myocardial perfusion. I'm going to comment on myocardial delayed enhancement and how we can use dual energy CT to assess for that. This is an example of a patient with sarcoidosis, and we can see top row shows the MRI, the CMR, late gadolinium enhancement with areas of linear mid-wall enhancement involving multiple segments in a non-ischemic distribution, which they closely match what we have on the delayed images obtained 7 minutes after injection of 1.5 milligrams per ml milligrams per kilo of iodine in the same patient, and using monoenergetic low KV images at the bottom row. We can also look at the iodine concentration and generate these color maps, which show basically the same finding. And myocardial delayed enhancement using dual energy CT has shown a sensitivity of 89% and specificity of 98% to detect chronic myocardial infarction. In cardiomyopathy, the use of mono 70 kV imaging may also provide an improved detection of myocardial delayed enhancement by decreasing beam hardening and increasing contrast to noise ratio when compared with standard CT. And in the quantitative realm, we can also see that ECV, extracellular volume measurements derived from dual energy CT, when compared with CMR measurements, they have a bias of almost zero, but still 95% limits of agreement. There is around 6%, which may be cumbersome for any clinical application at this point. So in summary, multi-energy CT has been introduced about a decade ago. There are some applications which are more mature now, some like CM contrast medium boosting, low iodine dose imaging, artifact and elimination, pulmonary perfusion, and virtual non-contrast imaging, but further investigation is still needed to consolidate other promising applications in pulmonary ventilation, oncology, and myocardial perfusion and delayed enhancement. Thank you.
Thank you, Fernando. Thank you, Rajiah. Now, Fernando will present the results of the SCBT-MR study.
Thank you.
Any questions?
Can you guys comment on the scan speed? So that's one, you didn't mention that, but in all these dual energy modes, if you were going to implement them, you're scanning necessarily slower than if you were in single energy. So does there become a point when the risk for more motion artifacts outweighs this added diagnostic confidence you get from dual energy?
Yeah, that's a good point. We have actually we switched back when looking at our PE studies. We had the impression that some of our studies were compromised by motion, and some of them were not actually perfect in terms of attenuation. So we had to review monoenergetic images almost 100% of the time. So we tried. So we have a dual source scanner. We switched to a flash acquisition for a couple of months to see if we would have better quality studies. And in reality, people liked the dual energy scans better, and we went back to doing dual energy scans. So even with the fact that you might have some more motion when compared to a flash scan, the fact that having the monoenergetic images at low KVs and the perfusion maps provide you more certainty in diagnostic terms. So it plays a role, and we encountered that empirically, but dual energy ended up still being our practical choice for now.
It also depends on the scanner also. This is the problem in dual source. You have multiple different ways in which you can scan, like a flash mode and also a dual energy mode. If you look at the other vendors, like a dual layer, so we don't have a high pitch helical mode. So doing a dual energy, I don't think it is necessarily slowing compared to a single energy.
Yeah, high speed issue here, like a twin beam acquisition where you're stuck at like a 23 pitch or something, like or rotation. Yeah, I agree with what you're.
We've had technical. I'm glad you had a thing on technical problems of implementation, because we've had a Siemens, like I described, it's a single source split beam scanner, and not many of them around. And we've had real trouble. The monoenergetic at the KV has been okay. It's not been hard. We have an obese population a lot of the time in the ER. It's just been real hard to implement because there's weight problems to impact quality. But we've had a lot of trouble just trying to get them to get the images with the iodine map. We have signal in the bronchi, and it's not turning out like the images SCBT-MR. There's no one to talk to. Their standard answer is just press the button and then it'll work. They're probably tricky bits for
yeah, I mean, we don't have experience with twin beam CT. So,
yeah, one of the things, at least with the Siemens system, the map that they would provide you out of the box is it doesn't correct for the pulmonary. All of the quantitative measurements that you do on the workstation, they rely on you putting a region of interest on your pulmonary artery. So in my experience, when you do that, the maps, they look better. I mean, you have more contrast between hypoperfused and normally perfused areas. So you might want to check that if putting the ROIs in the reference ROIs in the pulmonary artery would make any improvement in your maps.